Hello, I'm Dr. Nicholas Tedesco DO, Associate Program Director for the Samaritan Medical Group Orthopedic Surgery Residency, and as part of my academic year lectures, I'm going to be posting a series of topics online to use and supplement with what we're doing in the formal didactic sessions. So today we'll start off with primary total knee replacements. I do own stock in ROMTech, which was formerly ROM3 Rehab LLC. It is an orthopedic rehabilitation company, but has nothing to do with this talk or either of my talks that I'll be posting. So the first thing whenever we're talking about a knee is you've got to know your anatomy. And so obviously a lot of this stuff is simple, but it is very important when it comes to preoperative templating, explaining things to patients, and particularly picking out landmarks, especially in order to reestablish the joint line. So total knee alignment has to follow anatomic alignment. And so we have to talk about the coronal plane, both varus and valgus, the sagittal plane, which is femoral flexion and extension, as well as the slope of the proximal tibia, and then axial alignment as well, which involves the rotation of the femoral component and the tibia, and then therefore the patella placement and patellar tracking as well. So we'll start with the anatomic and mechanical axes of the entire limb. And so the anatomic axis is essentially splitting the diaphysis of both the femur and the tibia. The mechanical axis, however, is the weight-bearing axis with respect to gravity. And the gravitational axis is, in physics, what's known as the normal force. And so as you can see, with a valgus knee, you're going to shift that mechanical axis lateral. With a varus knee, you're going to shift it medial. In an ideal situation, the mechanical axis goes through the center of the hip, the knee, and the ankle. So what is the typical alignment of all of these things? So again, this is sort of one size fits most type of anatomy. Obviously, there's some variation in the normal human population, particularly with respect to height of the individual. So the anatomic axis of the femur is a bisection of the medullary canal. It roughly corresponds with the entry point of an intramedullary femoral guide when you stick it in during the case, as well as an intramedullary nail coming through the piriformis fossa. The mechanical axis is a line connecting the center of the femoral head and the intercondylar notch. This requires a neutral mechanical axis to share loads equally. So in a varus or valgus knee, you're going to get point loading medially or laterally, respectively. The distal femur tends to be 5 to 7 degrees off of this. This is what's known as the valgus cut angle of the femur, and that's the difference between the anatomic and the mechanical axis. The typical femoral neck shaft angle at the top of the femur is going to be around 135 degrees. Anything less than that we call coxa vara. Anything greater is coxa valga. The typical femoral mechanical axis is 3 degrees off of that normal axis, which is the gravitational pull, and 6 degrees from the anatomic, hence saying the valgus cut angle is on average 5 to 7. So therefore the anatomic axis is actually 9 degrees off of the normal force. The typical femoral neck anteversion with respect to the coronal plane is about 15 degrees. All of this is sort of what helps define the center of the rotational axis of the hip that helps us ultimately align the extremity, which comes into play primarily with computer-assisted navigation. So when we look at the distal femur head-on, when the knee is flexed, the typical femoral condylar angles in the axial plane from posterior to anterior are 10 degrees on the lateral side and 25 degrees on the medial side, with the posterior condylar axis defined as the slope of the posterior femoral condyles with respect to a horizontal line is about 3 degrees of external rotation. So now we get to the tibia and its alignment. So again, in the sagittal plane, the posterior slope of the proximal tibia is approximately 10 degrees. The anatomic axis is again a line bisecting the medullary canal. The tibial extramedullary guide runs parallel to this axis, and it's roughly equivalent to the mechanical axis if there's no prior deformity, whether traumatic deformity or rotational or bowing deformity of the tibia. The mechanical axis is the center of the proximal tibia to the center of the ankle mortise. The goal is to cut perpendicular to the mechanical axis on the tibia, and the normal proximal tibia is in about 2 to 3 degrees of varus to compensate for the femoral valgus. And this is evidenced by the fact that the lateral tibial plateau is always just a little bit higher than the medial. That's that varus alignment. So now the patellofemoral alignment. The biggest thing we talk about with this is the Q angle, which roughly corresponds to the axis of the quadriceps mechanism compared to the attachment site of the patellar tendon. So the most common complication after total knee arthroplasty is patellar maltracking. So you have to reestablish the Q angle of the individual that you're working with. It's the anterior superior iliac spine to the center of the patella, which again is roughly the axis of the quadriceps and the extensor mechanism, and then the center of the patella to the tibial tubercle, which is the patellar tendon, basically. In females, this averages about 17 degrees plus or minus 3, and in males about 14 degrees. Again, what we find though is it's actually more related to height than gender, probably. So distal femoral referencing, so similar to as we were looking above in the femoral alignment, where you have the 3-degree posterior condylar axis, there are other things that you can use to help determine your rotational alignment, which then helps determine your patellofemoral tracking and its axis. So you can use the true A to P axis, you can use the transepicondylar line, and you can use the posterior condylar axis. The AP axis roughly corresponds with what's called Whiteside's line, who is a physician who basically took the deepest point of the patellar groove and the trochlea on the femur, and that roughly corresponds with the A to P axis. If nothing else, where that deepest mark is does correspond at least to that particular patient's patellofemoral axis and alignment. So now we move on to the pathology that gets us here in the first place. So knee osteoarthritis is a non-inflammatory type of arthritis, although usually there is some inflammation at first. It's the most common form of arthritis, and the knee is the most likely joint to be affected by this disease. Other common causes of knee joint destruction include rheumatoid arthritis and post-traumatic arthritis, but there are many other causes as well. It's the leading cause of knee pain in the elder population, and prevalence is expected to reach 67 million in the U.S. by 2030. It's also expected to increase by 673% and 601% for primary and revision total knee replacements, respectively, compared to 2007 data. So as of 2018, 700,000 total knee arthroplasties are performed per year in the United States, and this number does continue to grow. So the American Academy of Orthopedic Surgeons came out with clinical practice guidelines to help out with treatment of osteoarthritis of the knee short of surgery, and tried to come up with evidence-based recommendations for what might be the best bets for getting the patient to feel well and function well without surgical intervention. And what we find is all of the stuff listed here on this slide, which is that viscosupplementation is probably not beneficial. It doesn't seem to play out when compared to needle lavage or placebo. Needle lavage, though, does seem to actually help somewhat. Acupuncture, again, mixed data on that one. Lateral wedge insoles, that's more for a typical varus knee deformity. You would not want to do that in a valgus knee. That might make weight bearing worse. Use of glucosamine and chondroitin, not specifically helpful or better than placebo. NSAIDs are helpful. Low impact exercise is also beneficial, as well as weight loss. So the history of total knee arthroplasty starts actually in the 1800s. Themistocles Gluck was the first man to ever perform an arthroplasty. It was actually in the hip and then the wrist, but he used ivory, and similar things were used elsewhere in the body. Otherwise, at that time, it was interpositional arthroplasty, where they didn't have the tools or the technology to replace joints, so instead what they would use is soft tissue or other means to sew in between the joint surfaces to prevent direct contact. In 1950, Waldius was the one who designed the first hinge total knee replacement. It was a constrained hinge with no rotational freedom, so aseptic loosening was very common. It was also a metal axle on a metal knee, so metal on metal wear debris was also a problem. In 1958, McIntosh and McKeever designed an acrylic tibial plateau prosthesis. In the 1960s, Gunston designed the first cemented knee replacement. In 1970, Guépard improved the Waldias design for hinge total joint, taking less bone stock and allowing for that rotational freedom now. And then in 1973, what we now know as the modern total condylar prosthesis was the first one to replace all the compartments and be able to sacrifice the PCL. So the Waldias hinge is there on the left. Again, you can see that metal axle on the metal implant, and it's a constrained fixed hinge. The McIntosh and McKeever was actually a series of unicompartmental replacements, preserving the ACL and PCL. The Gunston was the first cemented one, again, unicondylar components. And then the Guépard hinged was the one that finally had that yoke sticking up from the tibia that allowed rotational freedom. But in the 70s came on the total condylar knee, which is basically the resurfacing surgery that we now perform and we see today. So the concept of this is it finally incorporates femoral rollback, which we'll talk about in a minute, finally recognizing that the distal femur is actually a cam as opposed to a sphere. This introduced the concept of varying degrees of constraint as well as modularity and the ability to change sizes, depth, things like that to customize the components to the patient's anatomy. Designs that exist include cruciate-retaining, posterior-stabilized, constrained non-hinged, constrained hinge, fixed versus mobile bearings, anterior-stabilized, which includes total congruent and medial stabilized components, and gender-specific or custom components. So the femoral rollback involves the posterior translation that happens of the femur on the tibia as it goes from extension to flexion. Again, the concept of this is that the femur is a cam, which means it's a changing radius of curvature as it starts to roll back. So you can see in the picture on the bottom right, there's contact point changes from the femur to the tibia as the femur goes from extension to flexion. So what this does is it allows us to improve our range of motion so that the posterior femur does not impinge on the posterior tibia as we go into flexion. This is what allows humans to get 160 degrees of knee range of motion without dislocating the knee or significantly impinging. The way that the total condylar knee incorporated this initially was it created a post on the tibia with a cam and bar on the femur with a box cut that you make where the post fits into it. Then as the knee slides, the cam contacts the post, which prevents dislocation but allows for that rollback. So constraint to the knee is basically the ability of the prosthesis to stabilize the knee to varus and valgus stress as well as anterior and posterior force in the face of bone loss and ligamentous laxity. It's important when a cruciate retaining or posterior stabilized knee will not give adequate stability. Least constrained to most is cruciate retaining, posterior stabilized, varus valgus constrained, or what's called a constrained condylar knee, CCK, and then finally the rotating hinge. The modularity is what allows us to choose between all of these different constraint mechanisms, different sizes, all of that stuff. So it's the ability to change components of the prosthesis to balance the soft tissues, restore bone loss, and correct deformities. Options include a metal tibial base plate or an all polyethylene, metal augmentation for bone loss, and modular femoral and tibial stems, as well as different sizing and types of polyethylene available. The advantages are that you get to customize it intraoperatively. The disadvantages are increased osteolysis risk because you now have multiple different things happening to the polyethylene, multiple sizes, multiple wear properties. You have backside polyethylene wear because you now have multiple junctional sites of where the polyethylene is loaded. The other thing is that you have multiple junctions that can fail. So you can have structural failures at any of the junctions, whether it's the bone to femur, femur to polyethylene, polyethylene to tibia, tibia to bone. Additionally, some studies do show that a monoblock all polyethylene tibial component does actually last longer than the modular components, and likely for some of those issues that we just talked about. So now we get to those specific components. So cruciate retaining is the least constrained prosthesis. What that means is we retain the posterior cruciate ligament. The anterior cruciate ligament unfortunately does always have to come out with these in order to fit these implants. But what this does is it preserves the native posterior cruciate ligament. It's minimally constrained. Again, it allows for that femoral rollback to improve flexion range of motion and knee mechanics. And the indications are you have to have an intact PCL, you have to have minimal laxity in the joint that doesn't need much constraint, you have to have minimal bone loss, and you have to have a minimal deformity of the knee, because correction of that deformity often involves excessive strain on the PCL, or even partial or total sacrifice of the PCL in order to correct that deformity. So the advantage is it avoids that cam post mechanism. It resembles knee kinematics and probably allows for better proprioception, and it involves less distal femoral cut. The disadvantages is a tight PCL leads to increased polyethylene wear, and a bad PCL leads to flexion instability and subluxation. So if the PCL isn't that great to begin with, or if they happen to blow it in the future after the knee replacement is in, that's going to be an obligate revision surgery, which is a huge deal for the patient. So posterior stabilized now does sacrifice the PCL. Because the PCL does lead to flexion stability, you now have flexion instability when you cut this. So you do have to compensate for that by changing how much femur that you do cut, and now you introduce that cam post mechanism. This again allows for the rollback, but does allow for a new mechanism of failure of the knee, which is jumping the cam. So basically, in deep flexion, the cam can actually jump over the post and essentially dislocate the tibia posteriorly. One of the indications for this is a previous patellectomy, and that's because the patella and the extensor mechanism do act as a check rein to antero-posterior stability. When that patella is out and that check rein isn't as competent, you need to have a cam post mechanism to stabilize that knee, because the posterior cruciate ligament alone will not be enough with an artificial implant. Another disadvantage to this is patellar clunk syndrome, which is where a ball of scar tissue forms at the inferior pole of the patella. That inflection gets stuck in the box on the femur, and then as they go into extension, all of a sudden it will jump out, causing a big clunk. Thankfully, newer designs over the last 20 to 30 years have sort of figured that out, and we don't see that nearly as much anymore. So here's an image of that jumping the cam, pre-reduction on the left. So the tibia is subluxed posterior, and the patient is stuck in flexion. They usually cannot extend the knee. Post-reduction there, now you slide it back under. So the way you reduce this is you bring them into hyperflexion. You flex them as absolutely far as that patient will go, and then stick your arm back behind the tibia and pull forward with like a big anterior drawer type of pull, and then you reduce that back under the cam and post. So then we get to the varus valgus constraint, which is the constrained condylar knee. So it's a similar design to the posterior stabilized, but a much larger, thicker, stronger post that fills the box entirely. So it's not just A to P translation that it's preventing now, it's also varus and valgus by completely filling that box. The big advantage to it is it solves the problem of laxity or instability, but the big disadvantage to it is that, number one, it's now more constrained, which may lead to increased aseptic loosening, although that hasn't been borne out in the literature as of yet. It does involve more bone resection than a posterior stabilized, so revising these becomes extremely difficult and leaves very little bone behind. And the other issue is, because there's so much constraint now on that post, the post can actually fracture or have many other complications associated with it. The total constrained knee is the hinge. It's now a complete rotating hinge, so there is a yoke that goes down into the tibia that allows the polyethylene or femoral component to rotate on that, which takes out some of that excess constraint. With the popliteus muscle providing rotational motion throughout our motion arc, if you just have a pure hinge, it torques that knee that's stuck as a hinge too much, and eventually you have aseptic loosening or you fracture the component. So this way we solve that problem. The advantage is you don't need any ligamentous stability in order for this to work well. And so if you have massive bone loss or instability, then this works great. The big disadvantage, it increases constraint, leads to increased aseptic loosening. There's a large amount of bony resection that's required to fit these components in there. They're extremely difficult to extract or revise. And the rotation during motion does drive a lot of patients crazy. They're not super happy with it. The next thing is a fixed versus mobile bearing. So a fixed bearing is where the polyethylene snaps into the tibial platform. A mobile bearing is where the polyethylene floats on a very smoothly polished tibial platform, like in this picture here. So that polyethylene is free to translate and rotate on there, again decreasing the strain and constraint on the knee. The theory was this would allow for more normal mechanics and decrease polyethylene wear because things aren't so constrained. In reality, this actually turned out to increase polyethylene wear because of backside wear. So now you have wear not only on the femoral side, but also on the tibia side. You can also have bearing spin out. This can completely spin off that top of that tibia and dislocate. So these have sort of fallen out of favor and are becoming less and less common, although the concept is still used in medial unicompartmental knee replacement. An anterior stabilized knee is the use of a highly congruent anterior stabilized bearing for the posterior cruciate ligament substitution. So it's just like a posterior stabilized knee, but instead of cutting a box and having a post and cam mechanism, instead you have a fully congruent polyethylene with a large anterior lip that prevents that translation of it, and it keeps the femur more stabilized. The big disadvantage to it is it doesn't allow for as much of the femoral rollback. So as a result, you make the polyethylene thicker anteriorly and smaller posteriorly to allow for that range of motion and prevent excessive impingement. But what that can do is lead to some slightly abnormal mechanics and can have some problems. However, in studies, these have actually been shown to be revised less and seem to do better, and patients do tend to prefer these when they have bilateral knee replacements with this on one side and a posterior stabilized on the other. So here's a picture of that where, again, you have that big anterior lip compared to the relatively smaller posterior lip, and you can see the curvature of the polyethylene that matches the radius of curvature on the femur. Gender-specific knee replacement takes into account, again, the different gender differences in terms of the relationship between the A to P versus the medial-lateral ratio of the distal femur in men and women. It also takes into account that different Q angle and changes where it places the trochlea. Again, what we have found is this is more related to patient height rather than gender. So once upon a time, it was the male knee, female knee. Now the names have changed to, standard versus narrow, or things like that just accomplish whatever you need to accomplish intraoperatively for whatever patient you need to. MRI-based or patient-specific instrumentation is basically where you take an MRI of the patient's knee or a CT scan, send it to a company, they reproduce a 3D printed model of their knee, and then they can create custom cutting blocks based on preoperative templating for exactly where you want to make your cuts to reproduce the anatomy a little bit better. So it's streamlined surgery. You don't have to make as many measurements intraoperatively. It's quick, it's easy, it shortens operative time, which may therefore decrease blood loss. It allows you to reproduce the anatomy a little bit better and easier, but some of the theoretic issues are the blade tends to skive anytime you cut, and so you don't know if you actually cut it where the computer predicted you would, and there's no real way to verify that. The other thing is the studies have shown that although it does decrease operative time, it's only by about 5 minutes, which largely is meaningless in terms of cost and risk to the patient. Computer-assisted orthopedic surgery and robotic-assisted knee arthroplasty are two of the newest technologies. Computer-assisted uses an imageless system. It basically reproduces the hip-knee-ankle alignment by picking anatomic points on the patient with an infrared reader. It also establishes the center of rotation of the femoral head for helping to determine that mechanical axis. Then when you pick your points on the distal femur and proximal tibia, it essentially tells you where to cut the bone and allows you to place your cutting blocks and verify that. Additionally, after you make the cut, even with skiving of the blade, you can verify your cut, and if it's a little bit off, you can recut. The robot is very similar, except it does use imaging, and then the robot makes the cuts for you. It does much more accurately reproduce the anatomy. It does seem to be technically easier for the surgeon, but there are concerns that some studies initially showed increased blood loss, maybe because of increased operative time. The fiddle factor of the robot, although after getting used to the technique, surgeons tend to get faster and better, and it doesn't prolong operative time once that learning curve is over. The other issue was early studies showed increased risk of patellar tendon and soft tissue injuries, but now newer models of the robot compensate for that, and they actually won't allow the blade to go off of the bone. So it actually decreases the risk of soft tissue injuries. And many of the robotic systems that do increase the risk are not currently FDA approved or on the market in the United States. The biggest issue with the robot is most studies so far, even despite better alignment, are not showing any difference in outcomes or revision rates. And the robot is extremely expensive. It's a $1.3 million upfront cost to the hospital. Okay, so you have your patient picked, your implant picked, so what's next? Well, the first thing obviously is always preoperative discussions, the risks, the benefits, the alternatives, all of that good stuff. Total knee arthroplasty does put a substantial amount of stress on the human body. Mortality rate is 3% per year following total knee arthroplasty. So this does represent a large stressor, and many patients don't survive long enough to really reap the benefits of a knee replacement. So one of the most important parts of the preoperative discussion is determining risk factors and then therefore risk factor mitigation. However, there's a 98% survival rate at 10 years if the patients are under age 55. So obviously there's a correlation between age and survival and the increased medical comorbidities that tend to come with increased age. Additionally, you need to determine your anticoagulation of choice. The literature does not seem to prefer one versus the other, but in these days, aspirin seems to be more than adequate, and in really low-risk patients, perhaps even nothing at all, and just mechanical prophylaxis is adequate. When it comes to the heavy-duty blood thinners, especially for high-risk patients with a history of VTE or clotting disorder, when you look at the chest literature, the family practice literature, the anesthesia literature, the orthopedic literature, no one really stands out above the others, with the exception that Xarelto does seem to have the highest risk of wound complications and prolonged oozing. So that's one that I generally avoid. When I look at the stroke and heart attack literature, things like that, it looks like Eliquis really comes out on top in terms of having the best benefit with the least side effects. But that's obviously my opinion. Now, when it comes to planning, then, once you're finally ready and you're going to do preoperative planning and templating, you need at least a standing 30-degree flexed AP and lateral view, a standing AP view, a sunrise, and a full-length image from hip to ankle with a 36-inch cassette to determine their overall alignment and mechanical axis. So back to the adverse outcomes discussion. So many risk factors have been discovered and found that lead to adverse events after total joint replacement. That includes things like mechanical complications, unplanned readmission to the hospital, unplanned return to the operating room, mortality, all of that stuff. I highlighted the ones here that seem to be the biggest risk factors for adverse events following total joint replacement. When it comes to obesity, it seems to almost be a parabolic as opposed to linear curvature, that as you increase the BMI, you start to see a sharp rise in adverse outcome after a BMI of 40. Same thing with diabetes mellitus, where there's a sharp rise after a hemoglobin A1C of 8. And then some studies have found that a hemoglobin A1C greater than 7 represents a significant risk factor. So 7 or 8 seems to be the sort of cutoff there. So that brings up the absolute contraindications. Who should not be operated on? Who is unsafe? Well, non-compliance. If they are not going to comply with your post-operative protocols, things like that, Even though their x-rays may look fantastic, their functional outcome may be absolutely abysmal. So compliance is an important part of this, and along with that, appropriate mental health, counseling, whatever might be needed to help those patients. BMI greater than 50. There seems to be a pretty close to 100% complication rate in patients with a BMI greater than 50. The problem is some of those complications are very minor, something like a bump in their creatinine level that corrects just with fluids, all the way up to mortality. But the point is that's a modifiable risk factor that should be modified prior to considering surgery. Same thing, hemoglobin A1C greater than 8 for sure is an absolute contraindication. Greater than 7 is probably a relative contraindication. Continuous tobacco abuse. One of the biggest problems with that is going to be infection and wound healing complications. Tobacco needs to be stopped prior to surgery. So risk mitigation, modifiable risk factors. So things like tobacco, weight, obstructive sleep apnea, things like that need to be treated, need to be discovered, need to be helped and improved prior to considering surgery. Things like age, presence of a clotting disorder, history of a prior MI. There's nothing you can do about that. Those are non-modifiable risk factors. When we study this, we do find that if we delay surgery for these patients to modify their risk factors, it is effective in reducing their risk, and it's also very cost effective in terms of the cost of the adverse event compared to preventing that. Other things that help mitigate risk. Neuraxial and regional anesthesia is better than general anesthesia for length of stay, for complications, for pain control, all kinds of benefits with that. Periarticular injection and 24 hours of IV steroids have been shown to be effective at better pain control, which improves outcomes and length of stay in the hospital. Blood-sparing techniques, whether or not that's the use of a tourniquet, use of special instruments like the Aquamanus or something like that, and the use of IV, oral, or topical tranexamic acid. One additional measure of prevention of adverse outcomes is avoidance of postoperative drains. There's virtually no literature to support this. It only increases blood loss and transfusion requirements while not providing any benefit to the patient. So approaches to the knee, now that we're finally talking about the surgery aspect of the primary knee replacement, that's going to be your standard parapatellar, usually the medial parapatellar. There is a lateral parapatellar as well. There's the mid-vastus, the subvastus, the minimally invasive with quadriceps tendon sparing, the rectus SNIP, and the quad sparing procedures. The medial parapatellar is the workhorse of total knee arthroplasty. The incision is roughly midline. Some people put it off to the side, preferentially a little bit more to prevent kneeling directly on the scar as a possible pain generator. But it's a longitudinal incision and then full thickness fasciocutaneous flaps that get elevated on either side. The intermuscular plane is your incising between the rectus femoris and the vastus medialis when you're in the quadriceps tendon, which is the same nerve. Once you get down, medial parapatellar, as it's described, you go around the medial side of the patella to gain full elevation. Some people remove Hoffa's fat pads, some people do not. Some people evert the patella, some people do not. So there are many different techniques for accomplishing this ultimately. The mid and subvastus approaches came about to be more quadriceps tendon sparing and hopefully more minimally invasive, which might lead to better outcomes. Unfortunately, none of that has really played out. So the mid-vastus is exactly what it says. It's the B line in that image on the right, where it sort of cuts in line with the fibers of the vastus medialis obliquus and avoids the quadriceps tendon. The subvastus is the C line there, and that corresponds with cutting just distal to and going into the retinaculum more than anything to gain your arthrotomy exposure. Then, of course, there's the lateral parapatellar and medial, which are D and A, respectively. The lateral parapatellar is probably better for valgus knees, although still conventionally not used all that much. The rectus SNIP is used for more extensile exposures, especially during revision arthroplasty, but it helps preserve the patellar tendon by not overstressing it and increasing exposure proximally. Several studies have compared it to the standard medial parapatellar approach and haven't really found any difference in outcome scores. So it is a great means of cutting back across the quadriceps tendon, even into the rectus femoris if need be, and flipping open the whole extensor mechanism there to gain your full exposure. The quadriceps turn down is essentially a V-shaped incision, so your standard medial parapatellar arthrotomy, and then at the apex of that, you then turn down laterally and come out the lateral side at the mid-pole of the patella, and then as you can see in that image in the middle, it peels it open. The advantage to this is in really tight or contracted or scarred down tissues, it will allow you to close it in a VY lengthening type of procedure, which will lengthen the quadriceps. The lateral retinacular artery does course deep to the vastus lateralis and should be identified and preserved if possible to prevent patellar avascular necrosis, although even if patellar avascular necrosis develops, it's largely of minimal consequence clinically. The minimally invasive techniques in this image here were sort of minimal exposure where you could just barely see the distal femur, again designed to spare soft tissues. However, the retraction for this particular surgery was so intense it would actually rupture more and create more problems with the extensor mechanism than it had you not done this approach. So this really has fallen out of favor almost entirely. Dangers during the approach to the knee are the superior lateral genicular artery, as we just talked about in terms of its blood supply to the patella. The infrapatellar branch of the saphenous nerve does have to get cut in almost every single one of the patients, but it can lead to a postoperative painful neuroma where a genicular nerve blockade can be helpful, otherwise dissecting out the nerve and resecting the neuroma. One way to try and prevent this is that if you do actually see the nerve and encounter it during your approach, then you can cut the end short and bury it deep within the fatty soft tissues, although it's usually very hard to gain exposure of this particular small nerve. So now that we're through the approach and we're ready to begin the case, now we talk about our different cutting techniques. So there are several different theories of the surgical technique. There's the gap balancing technique, the measured resection technique, the modified gap technique, and then the kinematic knee. The gap balancing technique, the goal is to create equal rectangular flexion and extension gaps. Ligament releases are performed to correct fixed deformity, bringing the limb into approximate alignment before bone cuts are made. So the amount of bone removed from the distal femur is determined by the flexion gap thickness. Traditionally, this is used in posterior cruciate substituting total knee replacements. So typically, you would cut the tibia first, establish your flexion gap with tension on the femur, cut the posterior femur. Now that you've established that flexion gap, you want to equal that with your extension gap. So then you bring the knee into an extension and you determine your distal femur cut based on that. The tibia is cut perpendicular to the mechanical axis in the coronal plane with 4 to 7 degrees of posterior slope in the sagittal plane, largely dependent on the implant that you're using. Each of them will have a specified posterior slope, so you want to be familiar with your instrumentation. Another way to figure this out is to cut 2 millimeters or less off of the more arthritic compartment. And so you want to cut just below that subchondral sclerotic bone that develops. For the femur, the distal femoral cut determines the extension gap. It's cut perpendicular to the desired mechanical axis of the limb. Again, usually that's 5 to 7 degree valgus cut angle. The posterior femoral cut determines the flexion gap and rotation of the femoral component. When you're flexed at 90 degrees and you lift the femur superiorly, you fully tense the medial and lateral collateral ligaments with respect to the tibia, and then you can cut parallel to the tibial cut. You can do anterior or posterior referencing for this. Posterior referencing uses a fixed point on the posterior femoral condyles with the amount of posterior bone resected constant. So if you want to downsize your component, it means you're going to cut more anteriorly, which could risk notching. But it allows you to establish that flexion gap, which allows for a more well-balanced knee. On an anterior-based technique, it's a fixed point on the anterior cortex of the femur. So if you want to downside the component, you're actually going to cut more posterior femur, which may modify your flexion gap, which also may modify your posterior femoral offset and create problems with deep flexion. So there are advantages and disadvantages to each technique. Now, the measured resection technique is the philosophy of maintaining the joint line position where it is, and a properly positioned joint line is essential to proper collateral ligament and cruciate ligament function and used predominantly during preservation of the PCL. It accepts less congruence of the flexion and extension gaps. and it relies on reproducibility of the epicondylar axis, which is usually about 3 degrees externally rotated from the posterior condylar axis. So the measured resection technique involves cutting the tibia, again perpendicular to the mechanical axis and with a slope in accordance with the implant that you're using, and you want your rotation centered over the medial third of the tibial tubercle, which roughly corresponds with the tibial crest going down the tibia shaft. The distal femoral cut is then made perpendicular to the mechanical axis that you're looking for. Again, that 5 to 7 degrees of cut, which is the difference between the anatomic and mechanical axis. The amount of bone removed should be equal to the size of the femoral implant. So again, you're recreating the native anatomy as best as possible. Once you've established the distal femoral cut, then you come in and establish the posterior femoral cut. So the rotational alignment of the femur is essential for flexion stability and patellofemoral tracking. It's usually placed in 3 degrees of external rotation in accordance with the posterior condylar axis, using the transepicondylar axis, the posterior condylar axis, or Whiteside's line, as we talked about earlier. There are several methods for determining that, but those are the kind of common ones. So, the reference points for rotational positioning of the femoral component include the epicondyles, the trochlear surface, the tibial shaft, and the posterior condyles. So here are some examples of how you would do that. The kinematic total knee replacement is a philosophy where the mechanical axis only takes into account the coronal plane with these other techniques. The kinematic theory uses transverse axis of the femur, about which the tibia flexes and extends, the transverse axis in the femur, about which the patella flexes and extends, and the longitudinal axis in the tibia, about which the tibia internally and externally rotates on the femur. Performance is using patient-specific instrumentation based on preoperative imaging and planning, so an MRI-based total knee, for example. There's no difference in functional outcomes, satisfaction, or revisions, though, with this technique, and it is somewhat technically challenging. However, when it's done right, here's an example of the difference. Here's a patient that's had 2 knee replacements with mechanical alignment in their left knee, which is the right side of the image, and kinematic alignment on the right knee. You can see that despite the fact that their mechanical axis is very similar, which is what you're trying to reproduce, you can see the kinematic knee is probably more anatomic. It did not raise the joint line, and rotationally, it's slightly different. Additionally, we talk about physiologic varus when we put in an implant based on the measured resection technique, where it usually does end up in slight varus, which is sort of where the knee lives. However, with a kinematic knee, you can obviate that and, again, more accurately reproduce a flat, stable platform to bear weight on without any translational or shearing forces, which in theory may increase the longevity of the implant. Again, this has not been borne out in the literature. Patellar resurfacing. It's often considered controversial, but really it's not. There's virtually no literature to support not resurfacing it, and study after study that does look at this shows that there's either no difference in resurfacing or not, but if there ever is a difference identified, it's that revision surgeries are much lower in patients that had it resurfaced. So in reality, without increasing complications substantially, it does help prevent revision surgeries. You should resurface the patella. The technique is you want to cut off the amount of patella that's equal to the size of the prosthesis, or 1 millimeter more, to prevent overstuffing. When you overstuff, it gets too tight as they go into flexion and they can't regain full flexion, or it's painful, or both. You need to preserve at least 12 millimeters in native patella thickness to try to prevent fracture or failure. Overstuffing the patellofemoral joint, as we just talked about, gives pain, accelerated wear, decreased range of motion, increased patellar dislocations because of the stress and pressure on it that might want to spit it out of the trochlea. And so we just talked about what you want to try to preserve, but you want to never go below 8 millimeters of preserved patella. If you do, you will probably need some sort of augmentation or run into some problems with the patella. So patellar tracking, again, determined by the Q angle. Abnormal tracking is the most common complication after total knee replacement. You want to reproduce the Q angle. And so again, take into account those gender-specific or different available implants that you have in the system that you use. An increased Q angle will lead to increased lateral subluxation forces on the patella relative to the trochlear groove. This could produce possible pain, mechanical symptoms, accelerated wear, and even dislocation. Common errors that lead to increased Q angle is internal rotation of the femoral component, medialization of the femoral component, internal rotation of the tibial component, placing the patellar button too lateral on the patella, or cutting your knee in valgus. Now that you're through the knee replacement itself, now you've got the implants in, ideally during trialing of the implantation, that's when you now check your balancing. Balancing is the art of knee replacement surgery. That's where you try and make sure that in flexion and extension, the ligaments are tightened equally. You also want to make sure that there's not over-tightening, and you want to make sure that it's balanced in terms of how much small amount of laxity there is medially or laterally in varus and valgus stress. So ideally, when you stress in varus and valgus, both in extension and 90 degrees of flexion, you want about 2 to 3 millimeters of opening up and gapping of that joint line. Less than that means you might be overstuffing it, which means they may not get full knee range of motion, may be tight, it may be a painful knee, it may accelerate polyethylene wear. If it is greater than that in terms of gapping, then it's going to be a loose, sloppy knee, which can lead to persistent synovitis, sensation of instability, gross instability, and an unhappy patient. The general rule is if a gap problem is symmetric, then usually you need to modify the tibia, and if the gap problem is asymmetric, then you're going to need to modify the femur. So if you have an implant that's tight in flexion and tight in extension, as we just talked about, that's a tight knee. Again, it's a symmetric problem. So both flexion and extension have the same problem. You want to modify the tibia. So the solution, cut more tibia or downsize your polyethylene. If you're balanced in flexion and tight in extension, now you have an asymmetric gap problem. So this is going to be femur side that you want to modify. So the problem is you did not cut enough distal femur or you did not release enough posterior capsule. Usually you're going to see this in a patient with a severe preoperative fixed flexion contracture. So the solution is release the posterior capsule. I usually start off the femur only, check it again. If it still needs more, then I go off the tibia as well. And I do that with a Cobb elevator subperiosteally to avoid damage to the popliteal structures. The other solution to this is cut more distal femur. So if you tried releases, you still can't get it, then you've got to go back and revise your distal femoral cut and take 2 to 4 millimeters more. If you're loose in flexion, tight in extension, again, asymmetric gap problem, you're going to be working on the femur. So the problem here, your distal femur is too long. So what you want to do is resect more distal femur or use a thinner distal femoral augmentation wedge in a revision scenario if you're already putting augments on there. The other thing you can do is upsize the femoral component. What that does is it doesn't change the distal femur, but it increases the distance A to P. If you're using an anterior reference, you're going to increase your posterior femoral offset, which is going to thicken that posterior femur, which is going to tighten up your flexion gap. If you're tight in flexion but balanced in extension, the problem is you did not cut enough posterior femur or the PCL is scarred and too tight. So the solutions: decrease the size of the femoral component, again, decrease that posterior femoral offset, recess or release entirely the PCL and then change components to a posterior stabilize, resect more posterior slope in the tibia to increase your flexion gap, resect more posterior femoral condyle, or release the posterior capsule again. Problem with releasing the posterior capsule is that may also modify your extension gap. So then you may have corrected the problem in flexion, but now you've created a new problem in extension. So be careful to recheck after you try any of these techniques. If you're loose in flexion, balanced in extension, the problem is you cut too much posterior femur. The solution: increase the size of the femoral component, A to P only, or posteriorize the femoral component. So either augment the posterior femur or translate it more posteriorly by cutting more anterior bone. If you're tight in flexion and loose in extension, the problem is there's too much posterior femoral offset. So you want to downsize the femoral component, especially if it's anterior referencing, and use a thicker tibial insert until it's balanced. If it's balanced in flexion and loose in extension, the problem is you cut too much off the distal femur, so you just want to augment the distal femur. Leave the flexion gap alone and only build up the extension gap. If it's loose in flexion and loose in extension, here we are again with a symmetric gap problem. It means too much tibia was cut. It means you need a thicker tibia polyethylene, or you have to metallically augment the tibia. So if you're already looking at a 20 millimeter poly and you're still loose, then you need augments on the tibia to build that back up. If you're balanced in flexion and balanced in extension, that's what you want. Close her up. Now, for balancing when it's not necessarily a gap problem so much as you have the same problem throughout the arc. So you have a varus deformity where you're tight medially throughout the entire arc of motion. So it is balanced, meaning you have the same instability problems in flexion and extension, and maybe you're good laterally, but you're too tight medially. So that means the lateral side is stretched out, the medial side is too tight, and so you have to do some medial side releases to get that medial side to open up and match the lateral side. So the first thing you always start with is osteophytes off of the medial femoral condyle and the medial tibial plateau. You want to make sure you've removed all of the meniscus and its capsular attachments. You want to release preferentially first the deep portion of the MCL and capsule, and you want to slide that all the way around till you get to the posterior medial corner. Then as you sequentially release these things, you're releasing the semimembranosus and capsule. If you really need to keep going and you still can't get it balanced, you have to release the superficial MCL. This will probably release the MCL entirely, which means you're either going to need to balance the knee and then repair it there where it's balanced, or you're going to have to switch to a constrained condylar or varus valgus constrained knee implant. Another option might be to pie crust the medial collateral ligament, but be careful of over weakening it to where they rupture it postoperatively. So if you do a technique like that, you might want to put them in a hinged knee brace to protect that MCL while it scars back in. These are sequential releases, so you don't do all of this. You do one, check your gap and your balance again, do the next, do the next, do the next in that order, and stop when you've reached your equitable tensions. Now, if you have a valgus deformity, so the lateral side is tight, the medial side is stretched. So the lateral releases, same thing. You want to release osteophytes off the lateral side. During your approach to the knee, you want to avoid aggressive medial release. And then you have to start with your other significant releases. So first you start with the lateral capsule. I do this off the tibial side, and I do it with a bovie. Then as you come around anteriorly, if you need to, you may have to release the iliotibial band off of Gertie's tubercle, or you may have to pie crust it. If you're significantly tight in flexion on the lateral side only, but balanced in extension, then you want to release the popliteus tendon. It's a flexion-based tensioner because that's where it gets tight. Finally, your last resort is releasing the lateral collateral ligament. Just like if you release the medial collateral ligament, you will need to either repair it or switch to a constrained condylar implant. Finally, if you have a flexion contracture deformity, so as we talked about earlier with the gap balancing, it means that posteriorly their capsule is really tight. So you want to make sure you get all the osteophytes off the posterior femur and tibia, and then elevate the posterior capsule, again with a Cobb elevator if need be. And the final thing to do is you can subperiosteal elevate and completely release the gastrocnemius attachments to the back of the femur if you still can't get it fully extended even despite aggressive bone cuts. All of these releases are performed with the knee at 90 degrees of flexion to allow the popliteal artery to fall posteriorly so that you don't get into it. You want to correct the varus and valgus. Correction of valgus and flexion contracture deformities have the highest risk of peroneal nerve palsy. If this happens and someone wakes up with foot drop, you want to take off the dressing and flex the knee. So you want to make sure there's not restrictive dressings on like an ACE bandage or something like that that might be externally compressing the nerve. You want to flex the knee to take that tension off and tethering off of the sciatic nerve. And you want to observe this for 3 months and see if it will correct. If not, then you may have to do some exploration. However, one of the things and techniques that I use if I am pie cresting or removing the posterolateral capsule, I do use bovie because as it gets close to the nerve, it will arc and you will see the foot twitch. So you don't want to stick a knife back there where you don't know where that nerve is and you may actually transect it. So this is just a chart summarizing everything that we just talked about. And here's my pitch for Pacific Northwest Pride. This is the view east to the Cascade Mountains at sunrise off of the deck in my backyard. So I will leave you with that.